Good afternoon, everyone. Welcome to the Endocrinology Grand Rounds for today. And we are very pleased to have one of our own faculty, Rebecca Jeun, present today. Dr. Jeun joined us in October of 2023 and has really made an impact both in our clinical and educational activities here, and grown her clinical practice and also given a number of lectures to students and also here. She obtained her undergraduate degree from Rice University and went to medical school at Baylor. Did her internal medicine residency at Hopkins and went back to Baylor to complete her endocrinology fellowship. And after a couple of years at IU as assistant professor, she came here and has been here since October of 23. She has an interest in general endocrinology and also specifically in endocrine, the interaction between endocrinology and oncology. She has recently published a related paper on immunotherapy and type 1 diabetes. She also worked on some of the immunotherapy related diabetes in the past. So we are eager to hear from her about this topic of hyperglycemia associated with antineoplastic agents.
So thank you very much, Dr. Jeun, for the introduction, and happy to be speaking with you all today. So, of course, you mentioned the title of my talk, and what we're going to go over is basically some of the things for the general endocrinologist to keep in mind when we're taking care of this very particular patient population that we share with oncology, and how we can help better serve them. So for my disclosures, don't have any, easy enough. And for the agenda today, so we'll start with the clinical case and then go through the different classes of antineoplastic agents that are known to cause hyperglycemia. For these classes, we'll go over the proposed or known mechanisms. What I won't cover today is basically steroid-induced hyperglycemia, because I think that's pretty well-covered topic for this audience. And then for certain of the agents, I will summarize some of the current expert recommendations in terms of screening recommendations, as well as management guidelines, and some things to think about as some of the mechanisms vary and how we handle the hyperglycemia related to each of these agents may vary to a certain extent, depending on what's going on. So this is a case that is drawn from my own clinic for a patient that our service saw in the hospital, and then later followed up with me outpatient. So the chief complaint on admission to the hospital, this was last year, the patient came in with altered mental status. And he was a 79-year-old gentleman with a history of Alzheimer's and hypertension, and significantly Hodgkin lymphoma, who presented with altered mental status and had fallen, and his family had noted that he was also becoming hyperglycemic within the past couple of weeks prior to presentation. And on arrival, his blood sugar was 303 milligrams per deciliter. In terms of his oncologic history, very recently prior to that presentation, he was started on a combination of bendamustine and brentuximab, and he also received pre-medication with dexamethasone. The family had noted that he had previously had a baseline history of well-controlled type 2 diabetes with the most recent A1C of 6.2%, and he was just on monotherapy with metformin. And the family had noted pretty soon after, within the first week or two after his first treatment, he was developing hyperglycemia with blood sugars consistently over 250. And he was ordered for basal insulin actually right before coming in, but ended up coming in due to the fall and altered mental status. So otherwise, not a lot of other pertinent medical history or social history. He was overweight, no acanthosis nigricans on exams, oriented to person. He was not in DKA on presentation, and in the hospital, initially blood sugars were running in the 200s of 300s on point of care finger stick. He was also dealing with an infection at that time and was admitted to the ICU, who ended up starting him on an insulin drip with very high requirements, up to 38 units per hour at the peak of his requirements. And it actually required the drip for about a week until the insulin rates finally started to come down to about 3 to 4 hours, units per hour before being transitioned to a basal bolus regimen. So he was discharged on multi-dose insulin regimen, and then as an outpatient, his therapy with the bendamustine brentuximab was not restarted, as the presentation was attributed to that treatment, and instead he started on radiation therapy for definitive management. And we actually were able to essentially taper his insulin dose over the course of that 3-month time span. And then now he's currently just back on monotherapy with an oral agent. I believe he's on a DPP4 rather than metformin at this time. So just to give a little background terminology for the kind of the rest of the talk. So you'll hear me talking about different grades of hyperglycemia. And so this is from the common terminology criteria for adverse events. So in terms of reporting adverse events in various trials, and you'll see grade 1, 2, 3, 4, and 5 listed. So grade 1 is basically abnormal glucose above baseline, not requiring medical intervention. Grade 2 for a patient with diabetes is anything that causes a change in daily management, needs essentially change in therapy, or an oral agent is initiated for a new diagnosis. And then grade 3 is insulin requiring, and also indication for hospitalization. And then grade 4 is life-threatening hyperglycemia, severe hyperglycemia requiring urgent hospital admission and sometimes ICU admission, and grade 5 is death. So, sorry, my graphics didn't come out quite the same, but this is just kind of a graphic of all the different, basically complex, mechanisms that are affected by these by different agents and how they all lead to a common pathway of hyperglycemia. So, for example, the PI3 AKTI inhibitors and basically downstream effect is that they end up inhibiting glycogen production and increase glycolysis. Several agents, including the mTOR inhibitors, basically increase insulin resistance at the level of the skeletal muscle with decreased glucose uptake. And then there's a number of different agents like androgen deprivation therapy that will lead to increased visceral fat and insulin resistance in the context of weight gain, and disruption of energy homeostasis, which also will lead to hyperglycemia. And then there's quite a few agents that may act at the beta cell level and can cause both transient and permanent dysfunction, like the checkpoint inhibitors, L-asparaginase, and then cause decreased insulin secretion that also ends up in the common pathway of hyperglycemia. So we'll go through several of these over the course of this presentation. So I pulled this chart from a guideline document from the UK, and it was just a nice kind of table summarizing most of the different antineoplastic agents and sort of categorizing them by their class and risk of hyperglycemia and type of hyperglycemia that they cause in terms of sort of a more type 1 or insulin deficiency picture versus type 2, more insulin resistance picture. Now, I will say some of these, like busulfan and the midostaurin, they list like pretty high incidence rates, but some of these were drawn from perhaps the phase 1 studies or the reporting data where it's not clear what grade of hyperglycemia that we're really seeing. So I'm not going to go over every single one of these agents in the talk today, but we'll go over several of these classes, the ones that I think are most clinically significant that we'll see as endocrinologists, in the clinical setting. And So just to kind of loop back to the case of my patient, and just to kind of explain a little bit more about brentuximab in particular, we'll start with this agent. So this is a chimeric mouse human monoclonal antibody to CD30, and it's conjugated to a microtubule inhibitor that basically disrupts the microtubule network and ends up causing cell death in the oncologic in terms of that mechanism for its use. And so it's FDA approved for several different indications in lymphoma, with varying different treatment scenarios, including Hodgkin, systemic anaplastic, and relapse refractory large B-cell lymphoma. And so coming to what's pertinent to us in terms of the hyperglycemia. So interestingly, at initial approval in 2011, hyperglycemia was not mentioned in the side effect profile in terms of a toxicity. It is there now. And so the incidence has been reported up to 8% of patients with any grade of hyperglycemia, 6% experiencing that grade 3 or 4 more severe presentation. And so in the early like phase 1 studies, for example, this one from 2010, hyperglycemia was only noted at this higher dose. But as we have seen over the years with several case reports, and also in the case of our patient, at the lower dosages, we still are seeing cases of hyperglycemia. And notably for this particular agent, we're seeing a lot of very severe insulin resistance. There was one case report where this patient was requiring 2,000 units of insulin per day. So incredibly high requirements. Interestingly, there were 2 case reports where high-dose steroids were started, one for a patient who they were treating for HLH, and then another patient, the hypothesis was that this was a type B insulin resistance. And it seemed like both of these patients had decreased insulin requirements actually after starting high-dose steroids, which is a little bit surprising, but may point to an area of future study in terms of how we can best treat this condition. The challenge was those patients were both very critically ill with multi-organ failure and ended up passing pretty soon after within that hospital stay. So it's a little bit hard to know sort of longer term, if this is a viable treatment option. But there's some different speculated mechanisms, not quite well known, but one of the thoughts was maybe this massive cytokine release. But like in my patient, we saw that the hyperglycemia eventually does seem to resolve with withdrawal of the drug if the patient can get through that kind of acute clinical situation. So,
So then 92% not get hyperglycemia.
Yeah, the majority of patients won't get hyperglycemia, correct?
But then it says the mechanism speculated to be due to a mass of kinase release. So, like all of those 8% or whatever have a mass of cytokine.
I don't
Seemed
think
like
so.
that would be pretty easy to.
Yeah. So in that one case where that patient was treated for HLH, that was, part of the presentation that was sought there. But some of these other situations, like in my patient, it didn't seem like that was the presentation. So I think there's a lot of open questions about what the actual mechanism of and why the insulin resistance is so severe. So I think we just don't know enough about it because it's also relatively rare, like you pointed out.
So that's really speculative.
It's a lot of speculation, heavy speculation. So we'll move on to a different drug class. So IFN alpha. Personally, I've obviously I haven't been in practice that long, but I haven't shared a lot of patients on this recently. But essentially, there's several usages of it that are FDA approved, including for melanoma, lymphoma, Kaposi sarcoma, and so this agent binds type 1 interferon receptor to activate the JAK-STAT pathway, and then eventually result in transcription of IFN-inducible genes for its effect. And so from a glucose perspective, again, the data is limited to more case reports and cohort studies. And so there were several cases of essentially what the authors thought were new onset type 1 diabetes. And some of these cases were associated with pancreatic autoimmunity, although this will be kind of a recurring theme where a lot of the times after these patients develop hyperglycemia, then we're testing for antibody status. So we don't know the baseline, autoimmunity there. And then both transient and permanent insulin dependency have been reported in these cases. And then there were 2 large cohort studies from the 90s and looking at type 1 diabetes patients on, the incidence of type 1 diabetes development, I believe in hepatitis patients versus the general population. And so there was a higher annual incidence rate. Again, I think this is somewhat speculation, but some of the proposed mechanisms would be stimulation of counter-regulatory hormone secretion, impaired glucose tolerance, and impaired insulin sensitivity, and increased insulin clearance. And so this was a study in healthy subjects who were given IFN alpha and then had an oral glucose load. And so these authors were looking at the changes in glucose levels, glucagon, insulin, and C-peptide levels. So the top lines are the patients who had received IFN alpha, and there is hyperinsulinemia, so increased insulin production, but still higher glucose levels compared to the placebo or the patients who did not receive the agent. So there is definitely some changes in the response with IFN alpha on board. So moving on to a different agent, this is L-asparaginase. So this is a part of chemo regimen for ALL. And so essentially the mechanism is to deplete asparagine. And so if you think back to our known insulin structure in the amino acid sequence, there's 3 asparagine molecules in here. And so basically this can lead to hyperglycemia related to insulin deficiency. Again, this is seemingly a transient phenomenon that will start pretty soon after starting therapy and then often resolves after treatment discontinuation. In particular, though, when used in combination with steroids, there seems to be an additive effect in terms of insulin resistance, and that will further contribute to hyperglycemia. And the next several slides, we'll be talking about a very important pathway that's the subject of basically a lot of study and many agents that have been developed in the oncologic setting to act at different parts of this pathway. And so this is the PI3K, AKT, and mTOR pathway. And so it's common in a lot of different types of cancers to see abnormal activation. And these abnormalities are associated with multiple aspects of progression of the malignancy. And then in terms of the relationship to glycemic control, though, if you see kind of further down along the pathway, after PI3K, AKT, and eventually there is regulation of gluconeogenesis, glycogen synthesis, and protein synthesis. So in the presence of insulin, the insulin receptor will phosphorylate the insulin receptor substrate proteins linked to the activation of this pathway. So this pathway is really crucial to different aspects of insulin-induced glucose and lipid metabolism, and that's exerted through a number of different ways, including translocation of GLUT4 to the cell surface, changes in glucose uptake, glycogen synthesis, suppression of glucose output, and triglyceride synthesis as well. And so this is just a chart showing the FDA-approved PI3K and AKT inhibitors that are in use currently and the different cancer types that they are used in. And so hyperglycemia, due to what I just talked about on the previous slide, is actually considered an on-target effect of these agents. And so the hyperglycemia is quite a common phenomenon in patients who receive these agents, but the risk factors do vary in terms of baseline diabetes or prediabetes status, obesity, and those kind of things in terms of the risk of development of clinically significant hyperglycemia. So With these agents, we'll see hyperglycemia pretty early in the course of the treatment within a few weeks. This is another drug class where we'll see more transient hyperglycemia that can resolve with lowering or withdrawal of the agent altogether. But the rates of more severe hyperglycemia, the incidence rates are lower, although there are several case reports that you'll find in the literature of patients coming in with DKA or severe hyperglycemia. So it's not common, but it is definitely, there's a potential there for severe hyperglycemia, particularly in our higher risk patients. So this is taken from the SOLAR-1 trial for specifically alpelisib, which is one of the PI3K inhibitors. And so this was tracking the fasting plasma glucose over the course of 15 cycles and stratified the patients into patients with diabetes at baseline, pre-diabetes, and then normal glycemia in the green. And so as you can see, all of these patients experienced some elevation in the fasting plasma glucose after the start of therapy, but the effect was much more pronounced for patients with diabetes and prediabetes, as you might expect over time. And we see that they remained generally sort of elevated over the patients with normal glycemic control. These patients were treated for hyperglycemia throughout the course of their treatment, so that's why we see this decline as well. But this just illustrates that certain patients are more at risk for more severe hyperglycemia depending on their baseline characteristics, and so that's something that we should keep in mind when we're seeing these patients. So, and the next couple slides, I'll just talk through some of the proposed expert recommendations. This is specifically for this PI3K inhibitor, alpelisib, but we could probably extrapolate this to agents in this class. And so at baseline, the recommendation is for the oncologist to basically assess the risk of hyperglycemia based on a fasting plasma glucose and A1C level, and using our usual ADA, guideline recommendations, understanding if these patients have a history of known diabetes or gestational diabetes, if there's obesity at baseline, and then age over 75 years. And so if patients have prediabetes or diabetes, it's suggested to refer to somebody who specializes in diabetes management to help optimize glucose control. And so the lifestyle recommendations are pretty, common sense of what we, sort of would normally recommend in terms of a well-rounded, limited carbohydrate diet with complex carbs and lifestyle changes with activity. There was some interesting preclinical data that looked at keto, like very, very low carb diets, which actually did help in terms of the therapeutic impact, and this was in animal models of the. It was helpful in terms of the effect on the tumor xenotransplants, but actually had worse outcomes in terms of the animal well-being. And so there was apparently a very drastic deterioration in the general health condition of the experimental animals. So the suggestion is not to pursue a keto diet in this situation. I think that is reasonable also because, we have seen these case reports of patients coming in with DKA as well. And so if you're having hyperglycemia and then you're in a state of ketosis, I think just trying to avoid getting into that situation is ideal. And so interestingly, there was a survey of oncologists who frequently will introduce metformin at 500 milligrams per day about 1 week before starting therapy in these patients. There's not a lot of data to support that practice, but it seems relatively lower risk. So that is something to consider. And then just for patients and caregivers to be mindful that these are this is a known potential side effect of this class of drug. So a little blurry, but this is just a flow chart, going through kind of the management strategies. So, again, kind of, for this audience, I think this is relatively common sense. If you're seeing, a high risk patient, this patient will need more frequent blood sugar monitoring. And then if they don't have these risk factors, blood sugar should still be monitored at least in serum every 2 weeks and the A1C every 3 months. And just to advise these patients of the symptoms of hyperglycemia so that they can keep an eye out for them. So this is the suggestions for management in terms of the grade of hyperglycememia. So I did find it a little bit interesting because, and I'll focus actually more on the grade. Well, we'll start at the most severe. So the grade 4. So this is over for us 500 of blood sugar. So they recommend stopping the drug at that point and then starting or intensifying metformin if they're already on it, and to add pioglitazone for the insulin sensitizing effect, and possibly an SGLT2 inhibitor, and recheck a fasting glucose within 24 hours, consider insulin for 1 to 2 days. Personally, I think that may be a change in sort of, my habits, because if I see a blood sugar of 500, I'm not very excited to start an SGLT2 inhibitor in that setting, especially if there's, so theoretically some risk of DKA. And then usually I would, move towards insulin, but there's, some data because of the effect of SGLT2 inhibitors inhibiting the glucose transporters responsible for reabsorption of glucose, and then lowering, basically decreasing the hyperinsulinemia that's postulated to be more helpful in this particular clinical situation. And so there's some preclinical data that suggests that SGLT2 inhibitors will improve hyperglycemia in this context more so than metformin. But I think it's, has some more risk in terms of, the ketoacidosis aspect and, dehydration, that kind of thing. And so the other thing to note is that the insulin sensitizers are preferred to insulin secretagogues like sulfonylureas and meglitinides. And so that's mentioned due to the expected kind of negative effect on insulin on the PR3 blockade from preclinical data. So, but, I think basically if there's severe enough hyperglycemia, insulin, can and should be used in that setting. But if the drug is stopped because of the short half-life, patients have to be monitored very closely for hypoglycemia afterwards, and appropriate de-escalation of the regimen over time. For less severe hyperglycemia, I think, it makes sense that, we could start with monotherapy or dual therapy with the oral agents. But that's just something, this is a, sort of proposed expert opinion from the oncology literature. So, yeah.
Okay. I haven't used them actually this.
I know, yeah.
Mainly because for one thing, I also worry like the bone density and all that. Long time ago, they used to be direct chemical, which I know right now is not. So, like fluid retention. I was just surprised, but they have a lot of studies.
Yeah.
So it's just like, do they have grades of recommendation?
I think this is expert opinion. And this is, more related, I think, to the, sort of preclinical data in terms of like the insulin effect on the pathway. But I also, that's why I was interested to put it up here and see what everybody thought, because, yeah, like you said, I don't use pioglitazone very frequently. I often end up, stopping it for patients. Yeah.
It wasn't
Right.
But also at the same time, I worry about if that was the reason why they were trying to block the tumor, why are we giving something that will
Right. Yeah. Yeah.
do the opposite?
Yeah.
So
Yeah.
that's the
Yeah.
challenge that
Yeah.
so for everything go.
Yeah, yeah, exactly. Yeah. And then yeah, I think the other thing too is in the short-term setting, how, effective is, prio, and then, but I get, if patients are being continued on these agents, I think there's longer term, once they're out of the acute setting, the argument is, maybe SGLT2 inhibitors is reasonable, for a longer term usage. Once, things are a little bit more controlled, and if the dose, if the drug is reintroduced at like a lower dose, then it may be, safer to use in that setting. So I think, yeah, this is expert opinion as far as I could tell. And so that's going to be an area of kind of, I think, a further study, and, how best to manage these patients to, basically for us to control the hyperglycemia, but not interfere with the drug action. So yeah, I did think that was kind of an interesting recommendation there. So looking further, along in the same, pathway or sort of related pathway are the mTOR inhibitors. And these are agents used in particularly renal cell carcinoma and some neuroendocrine tumors. So we'll see temsirolimus and everolimus used. And so there is a high incidence of hyperglycemia in these patients and new onset of diabetes. And so these patients can also actually have relatively more severe hyperglycemia with higher grades of, grades 3 to 4 from 4 to 12% in the main phase 3 trial. So again, with these agents, generally the hyperglycemia is reversible with discontinuation, but it can depend on the duration of treatment and sort of the underlying patient factors. I have several patients on these agents sort of more long-term, and they still require, therapy, of course, even after they've been off of these agents, and mainly the patients who have a baseline history of diabetes. So I think, but generally what we see is that with withdrawal, this tends to be reversible.
The same thing that when you have like history.
Yeah, these are all acting in a lot of the same pathways. Yeah. And then sort of going at the top of this pathway. So looking at ALK inhibitors. One thing to remember is, there are, oftentimes multiple agents in these classes, but they may have different effects on blood sugars depending on the affinity to, their different receptors. And so specifically, we've seen hyperglycemia more with this agent, ceritinib, which is a second generation ALK inhibitor. And then in the early phase 1, when they were dose finding, there was a significant rate of hyperglycemia, actually up to half of these patients. But the later studies, I think with different dosages, and then also some of the later studies actually excluded hyperglycemia as an exclusion criteria. So we have less data sort of in the clinical setting in terms of the incidences of the incidence rate of hyperglycemia. There are several case reports that are out there in the literature, and then in 2020, there was a adverse event database study out of Japan, and so the odds ratio was higher for this particular agent in terms of development of hyperglycemia at 2.25 versus crizotinib and alectinib, which are two other ALK inhibitors. And so this is more of this particular agent is more associated with hyperglycemia than others in the same class. So we'll switch out of that pathway, and we'll go over to somatostatin analogs. And so this is an interesting group of agents, particularly for us. We'll see patients on octreotide or lanreotide, and then for the endocrinologists, we also use pasireotide, which is not for an oncologic indication, but in like acromegaly. And so for the somatostatin analogs, there's different receptors and different affinities for these different receptors depending on the agent. And so you can see both actually hyperglycemia and hypoglycemia due to the varying effects of these agents on the receptors, like preferentially octreotide and lanreotide for SSTR2 versus moderate SSTR5. And we know that pasireotide has a higher SSTR5 affinity, so we see a lot more hyperglycemia with pasireotide. But so for these patients, it can be kind of a mixed bag there. And particularly for patients on insulin, you do have to be careful about hypoglycemia because actually insulin sensitivity can be improved with lower glucagon secretion and increased uptake of the muscles. But if there's a, preferentially more of an effect on through SSTR5, there may be more hyperglycemia. And so octreotide is not used directly for cancer therapy, but is for management of symptoms in metastatic carcinoid tumors and VIP-associated diarrhea. And then lanreotide is used in carcinoid syndrome and more advanced neuroendocrine tumors of the gut and pancreas. So moving on to another class, so the tyrosine kinase inhibitors. This is a very large class and kind of heterogeneous class of drugs. But to kind of simplify, these are basically targeted agents that block tyrosine kinase enzymes, and they disrupt abnormal cell signaling pathways involved in tumor growth and progression. So, of course, these vary. Their use varies based on the genetic profiles, which some of these. This is for solid cancer. Or solid tumors and the specific cancer type. So I won't go too into detail, from our standpoint. But there are particular agents that are more associated with hyperglycemia, which is, again, kind of one of the themes of the things that we're seeing, talking about during this talk. So nilotinib is a second generation TKI, and it has greater selectivity for BCR-ABL and use in CML. And we can see, again, not a particularly high incidence, but can be more severe. So grade 3 or 4 glucose elevations in around 7% of patients after 5 years and up to 8.5% of patients after 10 years. Again, we'll see early changes in glycemic control within the first 3 months of patients, and it can be very common in the mild range with CML patients. And this figure, it was from a poster that was looking at glycemic regulation, particularly in CML patients on nilotinib. So this is the red coded icons, and then versus imatinib, and that's in blue, and then the non-CML controls in black. And so basically the way they did this study was they had patients, they had them exercise to deplete glycogen, and then did an intravenous glucose bolus, and then monitored 2-hour glucose tolerance and the insulin response. And then also did a dynamic FDG PET scan during a hyperinsulinemic euglycemic clamp. And I was looking at specifically the quad muscle uptake. And so basically what they saw was there was an increased insulin response. So there was hyperinsulinemia, if you can see like this here in the red, in the patients who were on nilotinib, but had poor basically glucose handling, and they didn't see significance in terms of the FDG uptake in the quads, but there was a trend towards needing lower glucose infusion rates during the euglycemic clamp. And so basically in some that suggests there's some changes that are happening with nilotinib that affect the skeletal muscle glucose handling on therapy. So this is not hyperglycemia, but this is an interesting effect that we've seen with imatinib specifically, and it seems to actually mitigate hyperglycemia and maybe improve some features in both type 1 and type 2 diabetes. And so this was an observational study in patients with CML and on imatinib, and it was looking at basically their fasting fasting glucose levels, and there did seem to be basically a decline over the course of therapy. And these patients, and sorry, specifically, these were patients with diabetes at baseline. And so that was kind of a interesting finding that led to some interest in seeing what else, these agents could be used for. And this is a phase 2 trial that was done a couple years ago, looking at actually imatinib for treating patients with recent onset type 1 diabetes. And so what they did see at 12 months was that there was more preservation of C-peptide production in the patients treated with imatinib versus placebo, but that effect wasn't maintained after that fact. And they also did see, I don't have the data up here, but decrease in insulin requirements over that time. It wasn't a long-term, durable response, and there were some limitations in terms of, side effects, but pretty kind of interesting data here in terms of, what other applications some of these agents might have in the diabetes realm. So, and we'll move on to some of the hormonal therapies. So specifically androgen deprivation therapy in prostate cancer. More commonly, GnRH agonists or antagonists are used to basically decrease androgen levels. Orchiectomy has also been used in the past, but that's less common. And then anti-androgen therapy may be added. And so with the lowering of the androgen levels, we do see an association with worsening glycemic control and rising A1C. And we do see, not unexpectedly, changes in lean body mass, fat mass, and insulin resistance. And when they've looked at meta-analyses, when meta-analyses were done looking at these data, longer-term ADT therapy defined as over 6 months does correlate with a higher incidence of diabetes. And so this was, this is from a meta-analysis looking at the overall relative risk of diabetes in ADT. And it is generally, we're seeing a signal for higher risk there. So those patients will also need to be monitored over a long period of time for development of hyperglycemia and management of that. Kind of in the same vein, looking at tamoxifen. So that's a selective estrogen receptor modulator. So this is a common agent used in women with estrogen receptor positive breast cancer. And so with, the effects on estrogen, there has been association with an increasing incidence of type 2 diabetes. This is particularly pulled from a study looking at Asian women diagnosed with breast cancer. And so you see the dotted line are the tamoxifen patients, and then the solid line is patients who did not get tamoxifen, and the divergence over time in terms of the increased incidence, the cumulative incidence of type 2 diabetes. So again, also these patients will require longer term, follow-up. And so for us to keep in mind that is a risk factor for development of diabetes down the road. And so moving to another class, so looking at 5-fluorouracil, 5-FU and their analogs. And so basically the fasting blood glucose, changes in certain studies that we've seen, pre-chemo and after chemo, there is, a trend towards, higher blood sugars. And so in some of the preclinical data, it suggests that there is basically impaired insulin production, and there has been shown delay in C-peptide secretion as well, and the decrease in the abundance of secretory granules in the islet cells. There's also some thought that these therapies can stimulate immune mediators in pancreatic beta cells. And so when following OGTT and C-peptide levels, this is kind of what has been seen over time. So for some of these agents like this, the incidence rates aren't very high and are less commonly seen that I've seen in the clinic, but it's something also to keep in mind when you're seeing patients on these regimens. So last but not least, a big topic of the day are the immune checkpoint inhibitors. So, these have revolutionized, cancer treatment over the last, several years at this point. And so these are specifically engineered antibodies blocking various basically checkpoint pathways to disrupt inhibitory signals from the cancer cells to the immune effector cells and allow the activated T cells to target the neoplastic cells. So, of course, as you probably all know, significantly improved, progression-free survival and survival in many different cancer indications. And you can see over the years all the different agents that have been approved. And so we'll have to become familiar with these names over time. And then also their different targets because the risk of endocrinopathies does seem to vary with the targets. And so particularly, this is one of the few situations where we see a basically development of type 1 diabetes type picture, essentially insulin deficiency that is not reversible. And so functionally, these patients end up behaving like a type 1. And so we'll require basal bolus insulin, kind of the usual things. We'll do CGM monitoring and insulin pump therapy. And but essentially, once the hyperglycemia is controlled, then we can have patients resume immunotherapy and continue on. And so there's some data that suggests that there may be an association with improved outcomes because, if you have an immune response, to the pancreas, are you also having, a greater immune response to the cancer itself? But that I think is still a little bit, not well elucidated. So this is a speculated, a hypothesis for, the mechanism. So the idea is that there's some underlying, initially environmental exposure or baseline risk, including patients who have, history of type 1 diabetes in their family, certain HLA haplotypes. And then normally, even if there's, development of autoreactive T cells, the B cell expression of PD-L1 can downregulate this. But when you're exposing the patient to an anti-PD-1 or PD-L1 agent, for during this treatment with immunotherapy, this sort of interrupts this normal interaction and then breaks the tolerance from these autoreactive T cells. And then that leads downstream to beta cell destruction and rapid insulin deficiency. And so this was from a summary of the previous case reports of immune checkpoint inhibitor related diabetes. And so you can see that we have seen it with a number of PD-1, less so PD-L1 agents, and then combination therapy. And then it seemed to be a male predominance, but this may also be related to the patient population that's being treated. And you can see a very high number are presenting in DKA. So kind of the classic picture is that there may be hyperglycemia that is more mild developing on outpatient labs, over a couple weeks. And then all of a sudden the patient, ends up in the emergency room with DKA. And so many of these patients test positive for antibodies after the fact, for pancreatic antibodies. And many of them also have a susceptible HLA haplotype. But again, a lot of this, this testing is done usually after the fact. But not all of these patients will test positive for these autoantibodies. And then, like I was mentioning, there may be some association with an improved response, although that's not, totally validated. And it is common to see other endocrinopathies alongside. So that is something for us to keep in mind when these patients come in, to be also keeping an eye out for thyroid dysfunction, pituitary dysfunction, and primary adrenal insufficiency. So many times patients, were discontinued, I think, previously. But again, like I said, for this particular situation, once blood sugars are controlled, usually on multiple doses of insulin on a basal bolus regimen, then patients can be safely resumed on therapy. So just to kind of summarize, obviously there's many different classes of antineoplastic agents that can cause hyperglycemia. There's these vary in terms of the mechanism, and also that will impact in terms of the treatment options that we considered, like our discussion on the PI3 kinase inhibitors, and what's the best agent to use there. I think the other thing to keep in mind are many of these are agents cause reversible hyperglycemia, so we do have to be careful to be mindful of the time frame that we would expect that the glycemic control to improve, and to closely monitor these patients if therapy is withdrawn. But for situations like the checkpoint inhibitor diabetes, as far as we know from the data, that seems to be an irreversible phenomenon, and so these patients will be continued on insulin therapy indefinitely. And then I think the other thing just to kind of keep in mind, all these agents, there's a lot of new agents being approved, every year, and there's, new trials. And so if you have patients on agents in these class, to be mindful of the hyperglycemia and the temporal association, because it may be something that, you're discovering that is, a side effect that wasn't previously known about these agents. But particularly if you know that some of the other agents in the class may cause hyperglycemia, that's something to keep an eye out for. So with that, I will finish up and take any questions, but thank you all for your time and attention. Mhm. That was in that set, yeah. And so, right, yeah. I think it was from older case reports where I think when this first was identified, it wasn't as known sort of what to do next. And so now we're seeing, I think if we were to do like sort of look back at our cases now, I think we'll see a lot less discontinuation of therapy. But I think, yeah. That part I don't know. Immunotherapy. Yeah, I think it was in that particular, cohort, they were just seeing a lot, but I think it was a little bit of an older paper. So I don't, so the data that they showed was the patients who responded to therapy and also, developed the diabetes and seemed to have maybe a better like partial or complete response. But I don't know about the patients who they discontinued therapy, what happened to those patients. Yeah.
They all very continue. So the autoimmune diabetes.
Yeah, that's also what we saw. I think, when I was a fellow at MD and when I rotated at MD Anderson a couple of years ago, it wasn't, I think at times it wasn't clear, like, should we continue? Should we, not, what should we recommend? Because that was still like an open question at that time was, the oncologist would ask us, should we continue? And so I think now with more data, everybody's had more experience treating these patients. I think it's a pretty clear, answer that they do well on insulin therapy and then can resume immunotherapy fine afterwards. So I think if we were to repeat that now, we would see a lot less discontinuation. Yeah. Yeah.
These things, trying to use immunotherapy to prevent type 1 diabetes.
Oh, yeah, I think.
Patients are being closely followed, so
right.
Might develop.
Yeah. So I think there's a lot of interest in that. I don't know that they've found, I think the things that we've seen are, if you have known pancreatic autoantibodies, you have the certain HLA haplotypes. We were looking at MD Anderson, we were looking at pancreatic volumes. because you see marked atrophy in these patients, and then also some of these patients present with pancreatitis that's asymptomatic before that. But I don't know, and I may have, missed that in my literature review recently of, are there any other very clear sort of identification, risk factors that we know that we can, identify which patients will have this? Because, you're right, it's not, the incidence isn't that high, but when they do come in, they come in very ill with DKA and end up in the ICU. So, yeah. Let me check.